Hello, good afternoon. My name is Thomas Zeller from the University Heart Center Freiburg-Bad Rotzingen in Germany, and I'm going to chair a session which is sponsored by Medtronic, and this is dedicated to how to treat patients at high risk for reintervention, and we would like to discuss this topic based on 3 dedicated cases. I'm here together with a dedicated panel. We have Dr. Shishibor, we have Dr. Parikh, and Dr. Monteleone. Probably I can just start with my presentation. Oops, just a moment. Okay. Do we have the slides?
Thomas, I think you're sharing your screen. You should have the slides and share your screen.
Okay.
Thanks.
Now, I'm sorry, it should come.
Yes, it's perfect. Thank you so much.
I'm sorry. Good. So this is a short overview about what we can expect to come within the next hour. First of all, I would like to give some introduction into the topic. First of all, we are not going to talk about off-label use of any of the products distributed by Medtronic. The participants here in this session, they are compensated as for the services here. So let's start here. What's the background of the entire session? It's basically the FDA announcement and recommendation, which is almost 1 year old now, and it was not changed since August 2019, recommending that drug-coated devices, either balloons or drug-eluting stents, should only used for patients at high risk for restenosis and repeat femoropopliteal interventions. And the big problem here is with this recommendation, if you look into the guidelines, there is no definition for patients at high risk for restenosis or reintervention. So how to identify these patients? Basically, we have some patient-related and lesion-related predictors, which we believe may predict high risk for restenosis, which is, for example, diabetes mellitus, which is renal disease as patient-related. Then, of course, lesion-related, it's long lesions, it's ISR, it's severe calcification. If you look into the long-term data of effectiveness of DCB in task A and B lesions, which are usually not considered as being at high risk for restenosis, we can see that primary patency is, I would say, very good. At 1 year, it's slightly decreasing up to 3 years. And the same holds true for reintervention rate. There are some differences between the brands that are available commercially in the US. And this is a busy slide, but it's important because it summarizes what the FDA recommendation reflects. Here you can see the freedom from reintervention, and at the bottom, it's the all-cause mortality rate. So this is exactly what we should do if we discuss with our patient what kind of treatment may be best for them on long term with regard to efficacy and safety outcome. The background basically of the entire discussion is one single study. It's a meta-analysis published in December 2018, showing a risk ratio of 1.93 of an increased mortality rate on long term if paclitaxel devices are used based on randomized controlled studies. Looking more close into the data set and adding patient information of patients lost for follow-up, this risk went down dramatically to 1.7 to 7. If you look in even much bigger real-world data sets, that means large observational studies, Medicare databases, or German claims databases, you can see that there's virtually no difference in terms of all-cause mortality for the use of DES or DCB. And for German analysis, we even found survival benefit if DCB had been used. And this is also supported by data coming from from my own institution, where we looked into the outcome of patients treated with femoral popliteal disease, comparing DCB with POBA. Important to note that the POBA cohort is absolutely paclitaxel naive prior and post inclusion into the study. And what you can nicely see in red, these are the survival curves for paclitaxel. This is the entire cohort. This is after excluding octogenarians, and this is the matched cohort analysis. So these are the references for what I was talking about. So any questions before we are going into the case presentations from the panelists side?
You know, Thomas, thank you so much for that overview, and especially on the safety aspect of it. I guess I have one question to you. Despite the data that you have shown, at least in the United States, the FDA has not changed their last recommendation, which was the third letter that they sent, maybe it was 6 months ago. I don't recall now exactly the time. So we have continued with that challenge. Any advice you have? I know you don't practice in the United States, but in general, given your knowledge and given what you do in this field, as a leader in this field, what is your overall advice?
Well, my advice is simply to mention the problem because we need it due to legal reasons. If you are talking with your patient about the upcoming interventional procedure, but what I would recommend, and this is very important for the individual patient who is treated in your individual institution, you should have access to your own data. You should do the same what we did. You should have the opportunity to tell your patient, look here, this is the individual risk you are exposed to if you are going to be treated in my institution with a drug-coated device. And if this data can exclude the risk, I would say you are more or less done. And I can't imagine that any patient will refuse to be treated. So, well, I believe we need to continue. And I would like to ask Sahil to give his presentation about drug-coated balloons. What is the clinical evidence for long-term effectiveness and safety that guides your practice?
Thank you, Thomas. It's a privilege to be here, and I'm going to share my screen here. Thanks so much for allowing me to participate in this session. My job in the next few minutes is to sort of go over the simple case, the patients that would be enrolled in the randomized trial. And I wanted to take the approach to piggyback off of what Tomas was talking about how we talk to patients about efficacy and safety as part of this calculus. So I'm going to start with a case. This is a patient of mine here in New York City. It's a woman in her 70s with type 2 diabetes.
I'm sorry to, can you please put it, use the slideshow icon on the top and right up all the way on the left upper corner?
Sure.
All the way to the left. Yeah. And then click the first. There you go. Thank you so much. Sorry about that.
Yep. So the patient's a 70-year-old woman in New York City. She's a housekeeper. She's very active and she has left leg cramping with walking, typical claudication, and is a Rutherford class 3. And she really relies on her legs to work, and her livelihood is dependent upon it. She's got diabetes, hypertension, dyslipidemia, and breast cancer that's been treated and is now cured. She's a never smoker and has a family history of premature atherosclerosis and is on appropriate medical therapy. Her physical exam was notable for hypertension that was not perfectly controlled and diminished distal pulses. And this was her exercise ABI. On the left, you'll see the resting ABI with the left-sided ABI of 0.72 and with diminished waveforms. With exercise, the left-sided ABI drops to 0.33. There's also some claudication physiology with relatively mild disease on the right side. And so this is sort of the typical patient that I see here. She is active, is vocationally and lifestyle limited. And so we talk about optimal medical therapy, but because of her need to get back to work, she really wants treatment right away. And she wants to be able to have the fewest disruptions to her work schedule, which includes having repeat visits to the doctor and or for repeat revascularization. So then, as is typical here in New York, many of our patients are Spanish speaking, and her son, who came with her to the visit, is translating as I dive into some of the discussion that we usually have about paclitaxel-eluting technologies. And this was last winter, sort of right in the heat of the initial phase after the Katsanos meta-analysis. So we have this conversation, and most of the conversations really go like this. The patient will say, "Doc, I trust you. What would you do if I was your mother?" And I usually say, "Well, I'll do my best to optimize your procedure, and I'll use drug-eluting stents or drug-coated balloons if I feel it's in your best interest." And the patients usually will say, "Okay, doc, that's all I can ask for." And so this sort of is the prelude to the informed consent conversation. And I just wanted to highlight that informed consent really allows us the opportunity to make patients understanding of the medical information that's relevant so they can make an independent and voluntary decision. And so we have to present the relevant information accurately and sensitively. And that includes primarily the diagnosis, the nature and the purpose of the recommended intervention, and the burdens, risks, and expected benefits of all options. And I think we focused a lot on the risk, but we haven't focused a ton on the benefit, and that's part of the calculus. And of course, here in the US, we're obligated to document this fastidiously in the medical record. I have taken my lead from a lot of the language that's been put into the randomized controlled trials in the space that have had to readjust their informed consent. And I'm going to read verbatim just for the moment. Meta-analyses of randomized controlled trials of paclitaxel-coated balloons and paclitaxel-eluting stents to treat peripheral artery disease in the FEMPOP arteries have identified an increased risk of late mortality at 2 years and beyond. The magnitude and mechanism for the increased risk and mortality is currently unclear. The analyses also demonstrated reduced revascularization rates with drug-containing products. The impact of future device exposure is unknown, as is the impact of other drug-containing devices. Physicians should discuss the benefits and risks of all available options with the patient. So we have used language like this in our consent forms, but more importantly, we just have the dialogue with the patient. So this is our patient when she came to the lab for her procedure. You can see the inflow is relatively clean, and she has a relatively short occlusion of the distal SFA with reconstitution via profunda collaterals. And as you'll see, she has pretty good runoff below the knee. So this is not one of those shock and all kinds of cases that you'll see from my colleague, Dr. Shishabor, shortly. This is a day in the life of a peripheral interventionalist. And this is the type of patients that would have been enrolled, I think, in the clinical trials. So the long-term data, I think, are important to discuss with the patients as you get to getting informed consent. You'll see here that the three largest clinical trial programs, the IN.PACT, StellarX, and Lutonix programs, have patency data out to 3 years. And I wouldn't get drawn into the trap of trying to compare randomized trials, but you can see that the IN.PACT data are very strong for primary patency at 3 years of follow-up and with a statistically significant difference at that time point. The overall clinical trial program, I think, is well known, and the long-term data for patency up to 3 years and TLR out to 5 years have been peer-reviewed and published with excellent core laboratory analysis and adjudication and with relatively low loss to follow-up. Here are the clinically driven TLR data published in Circulation in 2019, demonstrating a freedom from TLR of approximately 75% at 5 years for patients like the patient I described earlier, which is statistically significantly better than plain old balloon angioplasty. And you can see that with respect to these clinical outcomes, the days to the first TLR are substantially longer when you compare those two metrics. Safety is also quite good. There was no statistically significant difference in safety events, including all-cause mortality in this patient population. And these were the most carefully vetted patients of all the data sets. In addition, here's another cumulative incidence of mortality figure that reiterates the point that there's no statistically significant difference in mortality. And again, even if you have a diabetic substrate, whether it's a diabetic substrate or a non-diabetic substrate, there's numerical improvements in freedom from clinically driven TLR. And you can see that there's a consistent delta at each time point across the entire clinical trial landscape from years 1 to 5. So the patient that we treated got a relatively straightforward pre-dilatation and then a drug-coated balloon angioplasty and had an excellent angiographic result. And if I'm using the Zeller algorithm for treatment, we certainly would be done. This patient now is over a year out and has been able to resume work and is clinically quite active. And I think that this is the kind of result that one would expect if you were enrolling patients in your treatment the way we would have enrolled them into the clinical trial. So I would summarize by saying that the IN.PACT Admiral DCB has a strong long-term patency data for lesions such as the one that I've shown. Appropriate informed consent requires careful consideration of the benefit and the potential risk. I think we've been somewhat distracted by talking about risk in the absence of benefit over the last 18 months. And I think that the current FDA guidance recommends the individualized assessment of patient benefit and risk in any treatment algorithm. And so in my clinical practice, I've used DCBs and other drug-eluting technologies in a high proportion of patients, given their high likelihood of restenosis in the real world. Thanks very much, and I'm happy to take any questions.
Well, sorry, thank you very much. This is an excellent overview and introduction into this topic of informed consent and dealing with what's in the best interest of the patient. We have clearly seen that plain balloon angioplasty is inferior even in simple lesions. What's your experience in your daily practice? How many patients do refuse to be treated with DCB or DES during the informed consent process?
It's a very interesting question. So it's been, I can count maybe on one hand how many patients were concerned about this. And most of that was in the early time period when there was a little bit less clarity. I mean, I feel pretty confident with the data and I try to present it in a fair and balanced way. We've also moved, I think, an interesting change in the algorithm is to have a conversation in the office in as much as we can, so that there's time to adequately let patients kind of digest the information. We had been doing mostly same-day consent for our ad hoc procedures, and now we've tried very hard to have conversations ahead of time, and that's helped immensely. Patients, in fact, quite rarely say anything other than, please, doc, do what's best in your opinion.
Tomas, I wanted to ask a question with your permission, and to you and to Sahil and Peter. And I would like to push back a little bit about this idea that these DCB trials, we cannot compare them against each other. And to me, I'm thinking of all the people that are watching this and they're trying to make a decision. What device should I use? Yes, ideally, you know, you want a head-to-head trial, but realistically, how often we don't even get trial to see if one device is efficacious. We just talked about it for the past 2 hours this morning, let alone get to a head-to-head trial. These DCBs all have been studied in claudicants, Rutherford 2 to 4. They all have similar lesion length. They all have similar calcification, similar patient characteristics. Are they identical? No. But for the most part, we're not talking about CLI versus claudication. We're not talking about 30 centimeter lesion versus 10 centimeter lesion. To me, they're pretty much about the same, you know. So how, as leaders in the field, as people that folks are listening to us, how should we advise them how to select? Now we have 3, 4 devices. How should they select? Soon we may have another one, right? So Ranger. How should people select? Or is it just, you know, because we come on and we say we can do head-to-head and nobody's going to do the head-to-head trials. So what kind of advice should we give to people when they are dealing with 4 devices and they want to select the best for the patients?
Well, I believe we are in line that not every DCB performs the same. Yeah, right. Okay, so how to compare? Even if the study populations look pretty much the same, if you look, for example, on the performance of the control cohort, you can see that there are differences between the studies. So in some, the PTA cohort is in the range of 50% primary patency at 1 year. in the other study, it's 55 or 57. So this drives a little bit the difference between the DCB and the control cohort. But anyhow, I believe we have seen the curve where with the Levant study, patency curves are narrowing at 2 years. There's no difference anymore. So I would say it's fair to tell the patient, well, we have these 3 brands in your country, and we have 2 of them where we have long-term efficacy data, which are convincing, and the most robust data are definitely coming from the IN.PACT study program. We have so far 1 direct comparative study, which is the COMPARE study, comparing the Ranger and the IN.PACT. The 1-year data at least seem to be similar. What happens on long term is not yet decided because we don't have the 3-year data yet. That will become interesting, whether there will be a difference between a high dose and a low dose DCB. But I believe what you mentioned, I personally, I tell my patient, we are using this particular DCB. We have 12 different ones available in Europe, because I believe it's the most effective.
Yeah, I mean, I think Professor Zeller said it eloquently. I don't think I can add much to that. We certainly don't have the luxury of having 12 different devices in the United States, but
Thank God.
Yeah.
Thank God.
Nevertheless, I do think that the data stand on their own, and certainly the IN.PACT device is outstanding. I think there are other considerations that do weigh in sometimes. Certainly, we have in our real world cohort used long DCBs liberally, and having the availability of longer DCBs has improved treatment efficiency. And certainly, I think that's important. I'm hopeful that the deliverability over smaller caliber wires will be improved over time, and that may dictate some people's choices. But I think by and large, the data speak for themselves.
Yeah, well, thank you. We are a little bit behind our schedule, so I would like to ask Peter Monteleone to give his talk about planning your case for optimal patient outcomes. Versatility is essential. Peter, please.
Wonderful.
And while Peter is pulling it up, Thomas, we can go to 1:15. I checked with the folks, and we have 15 minutes to 1:15 if you like, if necessary.
Yeah.
Are we shared appropriately here? Can you all see my screen? Yeah. So first off, thank you all so much for giving me the opportunity to be here. I'm so honored to be here with this distinguished panel, and also to have the opportunity to discuss a technology that I'm really passionate about, which is directional atherectomy. We'll be talking about a couple cases that I think well demonstrate the versatility of directional atherectomy, and we'll also be exploring data supporting use of this technology in context of these cases. So to begin with the first case, a patient of mine, a female patient in her mid-60s, diabetic with an improving, though still elevated A1C, hypertension, and presented with a progressive history of lifestyle limiting claudication in her right calf, truly limiting of her ability to function, to interact with her family, to go to the store, to do the things that she needs to do. Her rest ankle brachial index on the right lower extremity was 0.61, on the left side it was 0.92. And so diving straight to the angiogram, so via left common femoral arterial access, she had an aorta-iliac angiogram performed through an omniflush catheter, demonstrated ectatic distal aortic disease, mild disease within the common iliacs as well as external iliacs. On the right of the screen, when we look at this off-axis aortogram, we see the bifurcation of the common femoral, and we see complete occlusion within the proximal centimeter of the SFA, within a calcified SFA. There's reconstitution distally, as we'll see later, but in the setting of this patient's true lifestyle limiting symptoms, we decided, of course, to proceed to intervention as planned. In that setting, a 7 French Ansel sheath was advanced over the iliac bifurcation, and with many decisions and opportunities for crossing, in this situation, we used a Viance crossing catheter over an 014 nitrix guide wire. that Viance catheter was advanced into the beak of the occlusion, as you can see on the right side of the screen. The Viance advanced swiftly and smoothly towards the reconstitution. To talk a little bit about the technology of the Viance crossing catheter, it's a coiled shaft microcatheter. It's got a 14,000ths of an inch central lumen, allowing for passage and exchange of 014 wires. The total diameter of the crossing catheter is 37,000ths of an inch. So at the end of the day, it's really not more bulky than a 035 wire in general. Using the catheter, and there'll be an illustration next, use a rapid rotation with the supplied torquer. The goal of that is to overcome orthogonal friction and let the head of the catheter actually engage microchannels and pass smoothly. So as you see in the supplied video, via torquing, orthogonal frictions overcome. The head of the microcatheter searches for the inlet into an actual microchannel, allowing it to pass and allowing it to continue smoothly, hopefully, ideally, intralumen into the distal vessel. As it passes into the distal vessel, you then have the ability to utilize that 014 lumen within the microchannel to advance any 014 wire down into the vessel. Indeed, that's what happened here, allowing us to pass from this proximal, very proximal 1st centimeter SFA occlusion down into the reconstitution of the P3 segment. So we advanced the nitrix wire. We then withdrew the Viance catheter, advanced an 035 Trailblazer support catheter over the nitrix guide wire, and took this distal angiogram, demonstrated intraluminal catheter presence with mild disease within the popliteal and retibial vessels. So what next? What do we do in this patient? Our diabetic 60-year-old patient with a 28 centimeter chronic total occlusion with at least moderate calcification proximally. What does the data say? Where do we go from here? When we think about these types of lesions, calcified, threatening, coming up to the ostial SFA and the common femoral into the P1 segment, we start thinking about utilization of atherectomy. There's quite a bit of data that exists in atherectomy, and it's worth highlighting here, especially in context of the data conversations we're having throughout this session, that when we talk about directional atherectomy, quite a few patients have been studied. So 800 patients within the definitive trial series, also the largest core lab adjudicated study of atherectomy in lower extremity PAD. So in definitive LE overview, so 800 patients were enrolled into the trial. Of these, approximately 600 were claudicants, approximately 200 with critical ischemia. And it monitored, with use again of directional atherectomy alone, primary patency by duplex at 12 months, as well as also monitored some safety data as well. Again, it's worth noting, this is purely directional atherectomy. This was also directional atherectomy using primarily the prior generation of directional atherectomy systems, TurboHawk and SilverHawk, and not the upgrades that we see in the Hawk-1 devices going forward. Definitive LE looked first at safety events and demonstrated low rates of embolization and closure and flow-limiting dissection. Also, with, again, prior generations of the technology, a bailout stenting rate of only 3.2%. And then looking at patency in the claudication population, using directional atherectomy alone with an average lesion length of 7.5 centimeters, primary patency in this population was 78% at 12 months. So that's primary patency using solely directional atherectomy. That was true across anatomic beds. It was true in the superficial femoral, it was true in the popliteal, and it was used in situations where directional atherectomy was used infrapopliteal as well, actually better within infrapopliteal lesions. Now, our patient was a diabetic, and of course, diabetics are high-risk cohorts for everything, ranging from interventions with medical therapy and certainly with procedural therapies as well. And looking at the 600 claudicant patients within definitive LE, 280 of those were diabetic patients as opposed to 318 non-diabetic participants. In this higher risk cohort, directional atherectomy and definitive LE diabetics was equally safe. Bailout stenting rates, despite the comorbidity of diabetes, were equally low. And then impressively, primary patency at 12 months was effectively unchanged. So despite the presence of diabetes in this patient, similar to that the patient we're discussing in this case, we had a primary patency at 12 months using directional atherectomy alone of 77%, similar and in fact non-inferior to that which we saw in their non-diabetic cohort. What about calcified patients? This patient, as we'll see, had at least moderate proximal calcification at the inlet to her chronic total occlusion. 133 patients within definitive or in this high calcification cohort. And again, in a higher risk group, looked at primary safety as well as primary effectiveness and demonstrated by core lab reported trials effective as well as safe utilization of directional atherectomy in this higher risk, heavily calcified cohort. With that in mind, we thought about what we would do in our patient again. And so our decision was to use directional atherectomy. surprising in the setting of context of this data with the HawkOne LX system that allowed for application of these benefits to our diabetic patient with heavily calcified proximal disease. That also, when we think about operational integration of this technology, allowed us for vessel preparation to allow for safe utilization of drug-coated balloon therapies. We were treating a long chronic total occlusion. We aimed for bulky plaque removal. And in addition to accruing these benefits, we were also particularly thoughtful about the territories that we were working. So we wanted to minimize risks of bailout stenting in classic no stent zones in the common femoral as well as the popliteal, thus allowing us to apply drug-coated therapies with decreased risk of dissection. And so towards that end, from an operational efficiency standpoint, we deployed a 7.0 Spider embolic protection device. Here it's being deployed directly through that 035 Trailblazer that we already had in place for our distal angiogram. We deployed it sufficiently distal within the popliteal for allow for performance of effective atherectomy and the collection chamber to be allowed to advance distally to allow for effective cutting. On our initial angiogram, this is purely after withdrawal of the Trailblazer, so before any atherectomy whatsoever was performed. And you can see that there's just bulky disease along the entire length of the vessel, and that total occlusion really travels all the way down through the vessel. After our initial passes, so our initial passes with directional atherectomy, already we're seeing effective clear reconstitution of the vessel. Note that the profunda is still outpacing the SFA. We haven't completed our directional atherectomy or our final definitive therapy. After removal of significant plaque burden, we then advanced to use of drug-coated balloon technology with a 6.0 millimeter impact. Now, it's particularly important to mention that because we had vessel preparation achieved with directional atherectomy, we weren't really trying to affect angioplasty. We weren't trying to open the vessel with utilization of a drug-coated balloon. This is inflation of a balloon to 4 atmospheres, just enough to allow effective deposition of the drug coating onto the vessel wall. It also allowed us to have safe low-pressure angioplasty at the ostia of the SFA and allowed us effective treatment all the way through from the origin of our lesion through the reconstitution. And our final angiograms look excellent. So no scaffolding present here from the origin of the SFA all the way down into the reconstitution segment. Obviously now we're completely outpacing the profunda, no damage or injury to the common femoral artery. Notice our collateral vessels are still in place. If God forbid something ever happens in the future, there's no occlusion of those, and we have an excellent result. Our Spider worked too. So when we think about utilization of embolic protection, particularly for long CTOs, particularly for calcified CTOs, this person had fairly good runoff, but nonetheless, we saw some material actually within the Spider and was safe and effectively removed. So with regards to our plan and rationale in this long CTO, we significantly debulked this vessel and we accomplished our goals. We used directional atherectomy. We allowed for the benefits in our diabetic patient with calcified proximal disease. We treated a long chronic total occlusion with bulky removal of plaque, as you see on the left. And operationally, even beyond the data, through vessel preparation, we minimized risk of dissection, mandating bailout stenting in these classic no stent zones of the common femoral at the top and the P1 segment at the bottom. Now, directional atherectomy is versatile. We just looked at a 28 millimeter SFA CTO, but directional atherectomy is equally applicable to below knee vessels. And briefly, this was a 48-year-old male who came in with right lower extremity first stage critical limb ischemia. And the angiosome being impacted was his anterior tibial. And as we can see, those perineal and posterior tibial was patent. There's significant disease down distally within the anti. Now, it's not totally occluded, it's subtotally occluded, but you can tell the perfusion pressure is likely significantly reduced, as we saw by his toe brachial indexes non-invasively, by how slow flow coming through that anterior tibial was. What do we do here? What does the data say here? Well, definitive LE also had an infrapopliteal cohort, 145 patients, some with claudication, 70 of which had critical limb ischemia, like the patient we're discussing. And looking at patency in this patient population, 84% primary patency. Also freedom from target lesion revascularization, 91% in these patients. Clinical outcomes as well, wound healing in 68% of patients, 94% with actually 12-month limb salvage rates. And in this situation, we put a long 6 French sheath, 6 French 90 centimeter up to the right popliteal, used an 014 nitrix through an 018 straight Trailblazer. We were able to wire straight through with that workhorse wire nitrix. And to debulk this bulky disease, we used directional atherectomy with the HawkOne device. Again, directional allows for targeted atherectomy. So we solely cut in the area where we saw that the lesions were. In fact, we had no risk of distal embolization, similar to some other atherectomy devices that mandate distal embolization. And in this situation, the improved crossing of the actual HawkOne device allowed us to cut all the way down to the dorsalis pedis. There's 2 centimeters of distal wire beyond that HawkOne device, and yet that device passes smoothly. We then did low pressure angioplasty. Again, this is a 3.0 atmosphere inflation with the nanocross balloon, as opposed to using the balloon for angioplasty. We just used it to further pack beyond what we treat the vessel we'd already prepared. And our final results, excellent. Perfect inline flow into the anterior tibial, now competing with the posterior tibial. And for the first time, we actually have wound blush at the level of the first digit toe ulceration. So in this patient, in addition to a nice angiographic result, we had complete wound healing at 3 months. And as much as anything, it truly demonstrates the versatility of directional atherectomy, a tool that we used in these 2 cases to treat a 28 millimeter 6.0 SFA, and we also used to treat a bulky disease within a 3 millimeter anterior tibia. So with that, I'll stop and take questions. Thank you all so much for the time.
Yeah, Peter, excellent demonstration of the benefit, at least the acute benefit of the use of directional atherectomy. You have shown us cases where we know that they are definitely at high risk for restenosis, long lesions, calcified lesions, small vessel diameters, BTK. So everything which supports the use of a vessel preparation system, at least to be acutely successful. So with regard to the SFA case, you could do it much quicker, and we don't know whether it may be equally successful in simply placing a couple of drug-eluting stents, post-dilate them, and you are done. So atherectomy takes a little bit more time than stenting. So what's the background why you don't go directly to stent? Why do you invest the time to prepare the vessel and to avoid stenting?
And that's a great question, especially when obviously we're always thinking about timing and efficiency as we go through some of these cases. It's worth saying the more you use directional atherectomy, the faster it becomes. The fact that we have that 035 Trailblazer for our distal angiogram that allows for spider deployment, that allows for utilization of the device safely, makes it very quick. Now, it's worth mentioning, to answer the targeted question, especially in long SFAs, there's certainly lesion length dependence to utilization of scaffold-based design. So when you start overlying multiple stents all the way across that SFA, your clinical outcomes decrease significantly as you go. And as we've seen early on with some data with drug-coated balloon therapies, we don't see that same kind of lesion length dependence and significant precipitant drop in outcomes as the lesion gets longer. If anything, also, as we see our interventional sites encroaching into the popliteal as well as the common femoral, the ability to safely avoid therapies there also, avoid placing scaffolds into that territories with risk of fracture, increases our net benefit to utilization of atherectomy as preparation for drug-coated balloons therapy as well. So in short, it's one more thing to add, we are so bad at treating in-stent restenosis when it happens. So even though we talk about primary patency, being preserved with scaffold-based designs where, sure, maybe at 3 years you have a 20% clinically driven target lesion revascularization, in that patient population that does have TLR, we are absolutely terrible at treating it. And so rather than saying, okay, let's just ignore those patients and try and do well 80% in 3 years, why don't we provide for a therapy that completely avoids utilization of scaffolds and provides for a net benefit in that group in the future too?
Yeah, one short remark with regard to TACs. Do you have experience with them? The background of my question is basically TOBA 3, which was combining the IN.PACT Admiral balloon with TAC implantation in dissected lesions. In your particular case, we saw some residual dissection at the re-entry area into the popliteal. When would you consider to use a TAC in such a situation? What appearance would drive you to implant something?
It's a very interesting question, and I'd love some insight from the rest of the panel as well on that. One of the things that's been exceptionally great about directional atherectomy is even if you end up using a stent, you're using so much less scaffold than you would have otherwise. You know, in general, I think the more atherectomy you perform, the more comfortable you become with quote unquote non-flow limiting lesions. You know, I direct our non-invasive vascular lab, and we follow some of these patients that have non-flow limiting lesions. Most of them heal. And so as time has gone on, we've used less and less stenting or post-atherectomy for therapies just for angiographically visible non-flow limiting lesions. TAC, I think, also provides a great benefit there. And in terms of the comparisons of the two, I'd love to hear the thoughts of the panel.
So Mehdi or Sahil, any comments on that?
Yeah, so we're early in our experience, Tomas, with TAC, and you know, I think that the concept is very attractive. I think that certainly the data that have been shown so far have been pretty strong, both for above and below the knee, and the combination of the DCB and TAC seems like an ideal one. I know that's how it was conceptualized, and the data seem to bear that out. On the other hand, you know, I think that practically speaking, the use of a short self-expanding nitinol stent in many practices is still the standard. And if you look at our DCB data with long lesion subsets from the IN.PACT series, for example, about half of those patients had bailout stenting with short nitinol self-expanding stents and had excellent long-term patency. So I think that you know, the point is well made that the TAC may be the next generation of a nitinol self-expanding stent. So for those that have access to it, it's a good technique. But I think even if you don't have access to it right now, using a short focal non-DES is a reasonable strategy.
One interesting strategy could be, well, you have prepared the vessel with atherectomy, you have performed your DCB angioplasty, and you see an area which does not look good. Well, you have your atherectomy device still on shelf or on the table. Now you have already applied the drug. Would it be reasonable to go in again with the atherectomy device? And if so, would you then need a second DCB in order to paint the vessel again with the drug?
Yeah, that's a great point. I think theoretically, you're right on that if you come in with an ablative strategy in those areas, you might be setting yourself up for having a relative paucity of drug. So I think if you were being a truist, you would want to come back and repaint it with drug. It's impractical and it has cost implications. And so that's why the TAC strategy is a nice choice. I agree with you.
I have one technical question to Peter, again, to the below the knee case. Well, in the SFA, you did use a spider filter. Below the knee, you didn't. What's the rationale for it?
Initially, early on in experience with Hawk 1S, I used to use filters, you know, thinking it would behave like when we use filters in coronary devices. Tibials seem to spasm more for whatever reason, and more importantly, from an operational utilization standpoint, the diameter of the distal collection chamber on the Hawk 1S device tends to be almost as wide as the vessel itself. And so as you're cutting down with Hawk 1S, the opportunity for material to embolize beyond the collection chamber into the vessel becomes quite low. And it is an important comparison to other atherectomy devices. You know, any atherectomy device which is aimed at creating microemboli intentionally, you know, similar to the stuff that we use in coronary beds or leg beds. The notion of dumping some of that material down into a non-healing, you know, vasospasmed wound bed, as opposed to the ability to drive it directly in the collection chamber, remove it from the vessel, it is a real difference. That's kind of why I do as much directional as possible. Now, do I do directional atherectomy in a 90-degree bend, you know, within the anterior tibial? Those segments I'll sometimes try to avoid it, but short segments like that demonstrated in this case, bulky disease like that demonstrated in this case, you can really safely use directional without distal embolic protection.
Yeah. I believe your remark with regard to the wedge position of the device is the most important one. Why we may not need to use a filter below the knee, because if you have no flow downstream, you cannot lose any material. Well, very good. So now we are going to the last case, to the last frontier. Let's say, Mehdi, it's your part now pulling it all together to reduce reintervention in advanced peripheral artery disease. What tools to choose and how to use?
Well, you guys have done such a fantastic job, and I don't know what I'm going to add. But I'm very honored that you have allowed me to participate, and I'll try to go through this quickly. As you have highlighted, we have many options available to us. We obviously have a crossing and re-entry device, as Peter showed nicely with the Vions. We have debulking strategies, as we discussed earlier this morning, and as Peter beautifully showed with those two cases. And also we have anti-restenotic therapy, as both Peter and Sahil have shown with the cases that they have shown us so far. We do have angioplasty and specialty balloons, but we are learning more and more. And I think, Tomas, you have really highlighted that even for short lesions, angioplasty alone is not going to work for us. We use them to prep the vessel and to get us what we want, but these are just to get us going. These are not going to be the definitive therapy. And we also have a stent. We have drug-eluting stents, and we have bare metal stents. So how do you put this together when you're dealing with complex patients? And I have this 40-year-old female who also came to us, like Sahil's patient, with severe right calf claudication. She has a lot of comorbidities. EF is 20%. She's diabetic, similar to all the patients that we deal with. And she had prior coronary artery disease with prior CABG. Here's a PVR. On the right side, you can see the ABI is 0.59. On the left is 0.80. But I always exercise my patients with claudication. The reality is that patients with claudication have symptoms when they walk. They don't have symptoms at rest. So that 0.59 really is not very informative, in my opinion, unless you're willing to treat it. If you're not willing to treat it because you think it's mild, then you need to exercise the patient. And when we exercise the patient, the ABI was 0.23. I can tell you, I don't think I can walk much with a 23% blood flow. So my willingness to treat this patient is obviously much lower with an ABI of 2.23 after exercise. So we took her in for an angiogram. The common iliac artery looks great. The external iliac artery looks reasonable. But as Peter showed in his case, this patient also has a proximal SFA disease. Luckily, there is a nice little short knob. And then on the last panel, you see that the disease in this case actually extends all the way. There's some reconstitution, but then there is again an occlusion or subtotal occlusion, which extends all the way to the P2 segment. So we try to cross these as like many of the total long SFA lesions in an antegrade fashion. Here I have a Navicross, and that looks like a glide gold, but we probably started with a stiff angle glide wire and a Navicross, and we try to cross the lesion, and we are in subintimal space. Now, I am also in the camp like you of leaving no stent behind. So I'll try to stay luminal because I think that gives me many more options. But importantly, it allows me not to put a stent. I think there's less likelihood of using a stent if you're luminal. So in this situation, instead of using a re-entry device, which also I think is not very cost effective in my opinion, I decided to get retrograde access. So we quickly got a micropuncture needle, and that's a VAT, that's a command 018 wire. We were able to get popliteal access. We were able to quickly cross this lesion in a rendezvous fashion using a CXI support catheter and a command 018. We are now luminal, and that gives us many options as to how we want to treat this patient. We obviously quickly take a nice runoff to understand the runoff so we can plan our strategy and also understand if there is an embolization during the intervention. The runoff looks great here. So in summary, we have a 40-year-old female with Rutherford class 3 severe claudication, a 35 to 40 centimeter total occlusion of the SFA and the proximal popliteal artery with 3 vessel runoff. So how should we approach this lesion, at least from an endovascular approach? And in my view, I think that there are many approaches, but I think this is the one that seems to me the most ideal. And this is the work that you have done, and the definitive AR really brings it home for me. Although the study did not meet its primary endpoint, but it really highlighted something that I think Peter showed very nicely in his case. The study, we have heard this study many times, 120 subjects, Rutherford 2 to 4, lesions of 7 to 15 centimeter. So actually shorter than what I have shown you here. But the concept was, can we do directional atherectomy plus DCB and have a better result compared to DCB? We are always talking about what is the addition? How does adjunctive atherectomy add to what we do? And that's what this trial was getting at. The primary endpoint was target lesion percent diameter stenosis at 1 year. Again, the study was a small study. It was hypothesis generating, and you can probably speak to it a lot better than I can. But I think this is what we learned from this study. This to me is the most important, that if you do a good atherectomy, if you get less than 30% residual stenosis, regardless of whether you assess by ultrasound or by angiography, you have much better patency. If you don't do a good job, if you just pass the device quickly and you treat atherectomy like putting a stent, then your outcome, you're probably not making much of an impact. So we really need to pay attention on how we do directional atherectomy, where is the plaque located, how many runs we do, and obviously also protect so we don't get distal embolization. As you become more aggressive with your atherectomy, you want to make sure you're protected, and Peter nicely showed that. So in this case, we did the same thing as Peter, and this is kind of boring after Peter showed that beautiful case, but this is basically a spider filter that we place in the P2 segment. We then came with the Hawk 1 LS, and actually that day we had ran out of the LX, which is the 9 centimeter nose cone, which is much more efficient. So I ended up using this. And so the question was, after doing multiple runs of this, what should I do now with this lesion? And honestly, I think this is a silly question these days. There is no doubt in my mind that the treatment of any lesion, especially long lesion, regardless of whether you do an atherectomy or not, should be DCB. And the question is that, how do DCBs perform in long lesions? And we have a lot of data to show us this. I would argue that in the long lesions, you should even be more willing to use DCB rather than the short 3-4 centimeter lesions. And this is a study that was a subgroup analysis of the global registry of DCB that Medtronic ran. You can see they included ISR patients, long lesions greater than 15 centimeter, and CTOs. And look at the data: freedom from clinically driven TLR, and with lesion length of 28.7, almost 29 centimeters. And again, primary patency, both analysis shows fantastic result of 89.1% patency at 1 year. Honestly, for a 30 centimeter lesion, which is similar to the lesion that I was going to treat. So really, the drug elution has revolutionized how we treat these patients. And in this situation, we went in with multiple DCBs, as I have shown you here, and we attempted to deliver drug to this patient. Again, following what Peter has suggested. And you asked a very good question about Peter. So this is the angiographic result we had. Honestly, when I look at it right now, I'm like, man, why did I do what I did, which I'm going to show you. But to me, I was concerned. I did not take hemodynamic in this situation. I think maybe that would have been reasonable, and maybe we can discuss. But I think the flow, and I've learned from you that you look at the profunda and the SFA, if the flow is the same in both, you leave it alone. In this situation, I was uncomfortable because of the length of the lesion to leave it alone, the proximal segment, and I felt like stenting it would be better in trying to keep this long lesion patent over time. So, and is there any data for that? We discussed that briefly. How do you treat dissections, and does stenting hurt your patency? And I think Sahil also mentioned this. And we do have data. Luckily, there is a lot of data, and I want to applaud, the companies, especially Medtronic, for giving us all this publication and all this data, because we really can make our decisions based on data rather than anecdote. So this was an analysis of a stented versus a non-stented cohort of the global registry. So 353 patients that were stented versus 1,000 patients that were non-stented. And look at the data and the reasons for stenting. So the reasons for stenting: persistent residual stenosis of greater than 50%, 59%, and flow limiting dissection, which is kind of what I have here, or a combination of both, was another 53%. And I think my situation was a combination of both of these. But look at the data. This is up to 4 years for long lesions with bailout stenting. And again, Peter highlighted this very nicely. Rather than stenting a 35, 40 centimeter lesion, now I can just stent 7, 8 centimeter. So spot stenting or using TACT device, as you highlighted, which is a very wonderful device in trying to bail us out in this situation. So the data speaks for itself, in my opinion. 74% and 70% patency up to 4 years, stented versus no stented, no difference. it gives us the patency that we want. So I decided to put a stent here. Again, we discussed whether it was necessary or not. You could have used the TACT device, maybe get a shorter stent and take care of the process. And after putting the stent, this was our result. This was the distal flow, and proximally, you can see that the result is very reasonable. I wanted my last slide. We are excited about the reality data that's going to be presented in the fall. Again, these are 8 sites in the United States and 5 in Germany. Lesion length are shorter than the patient that I showed you, 8 to 18 centimeter. But I am looking forward to seeing some of the data and understanding the role of intravascular ultrasound and directional atherectomy and the DART concept together and how that data looks. Thanks again, Tomas, for allowing me to present.
Yeah, well, Mehdi, excellent. And this case is raising a lot of questions. You already mentioned how to best deal with this origin of the SFA. Is standing the right way. You paused a little bit during the case presentation, asking what next after directional atherectomy. That's a very important question because I believe you directly went to DCB after atherectomy, or did you predilate?
No, I don't typically predilate, to be honest. I mean, my algorithm is a little bit, I saw your algorithm this morning, which was beautiful. And I obviously do a lot of the things. I follow your algorithms and your advice because I've learned so much from you. But my algorithm, honestly, I believe that we need drug elution for all the patients, for all lesions. So I typically do angioplasty or atherectomy, whatever my adjunctive therapy is. And then I deliver the drug. And I've been surprised, honestly. Many times I thought that I'm going to have to stent, and I didn't need to stent. Or I thought I was going to stent half of the lesion, ended up stenting only 1/3 of the lesion. And then after that, I spot stented. So that's really my algorithm. And for more complex lesions, like popliteal calcified lesions, I'm usually atherectomy, DCB, and then if I need to put a supera, I put the supera in there. So that's really my algorithm. I would say that almost every patient that I treat now gets some kind of a drug elution. And most of them are drug-coated technology.
The key question is, should there be a second or an additional step between atherectomy and DCB, meaning testing the vessel, whether the lesion is responsive for the DCB, meaning, well, performing either a plain balloon angioplasty or even using a chocolate balloon. Chocolate rationale would be to avoid dissection creation, something which resulted at the end to the stent implantation in your particular case. So what's the opinion of the other panelists? Are they also going directly to DCB, or have they a step in between?
No, Tomas, it's a great question. I mean, I guess we have been married to using a predilatation, usually with a 1-to-1 sizing, both to test the lesion and also to see what kind of a response I can get with a more dedicated balloon, particularly if I need a focal force balloon, like you described. Chocolate would be a good example in that ostial location. Sometimes I've regretted it, particularly if I get an edge dissection. But most of the time, I feel like it gives me a better angioplasty result. I feel like the DCB's role is really to act as a drug delivery device as opposed to an angioplasty technology. And so I usually have an interim step. And I do that in particular in calcified lesions, even if I've done prep with a atherectomy device, because I've been surprised. There have been times where you get a particularly resistant lesion, and if you go in with the DCB and it doesn't expand, you might have to do adjunctive treatment. Even if it's just plain old balloon angioplasty, there is that theoretical risk that you'll disrupt the drug delivery that you've already tried to deliver with the DCB.
Yeah, I would say the big advantage, Peter, before you jump in, preparing the vessel with at least PTAs. If the vessel is not reacting on PTA, you can still go in again with your directional atherectomy system. What is more difficult if you have already applied your drug, Peter, I didn't want to interrupt you.
I apologize for interrupting you, of course. I typically don't do angioplasty prior to drug-coated therapies. The caveat to that, though, is if there is a somewhat recalcitrant area after atherectomy, if there is residual stenosis, I tend to put a regular balloon down, do a low-pressure inflation, and then use the fluoroscopy swing to find the angle in which that recalcitrant segment actually is. So you'll be able to identify in which lateral contour your refractory area actually is. And then rather than ballooning it, I'll set my II, I'll draw my little picture on the screen, and then I'll work on particularly atherectomizing out that section. So it's almost that concept of diagnostic angioplasty, you know, low pressure balloons allowing you to identify exactly which territory you want to work with. Most of the time I go directly from atherectomy to drug coating, but that's how I deal with those territories.
I think, Tomas, one thing we should say is that 100%, I would suggest that 100% we should take an angiogram after atherectomy. I apologize, I didn't show the angiogram because of the things that we mentioned, meaning that we want to make sure that we have less than 30% residual stenosis. And we want to do exactly what Peter said, is that if there are focal areas that you go back, and I love how Peter describes this, we really need to get away from this idea. You know, we were trained in a wrong way, to be honest with you, I feel. Because when we were doing full metal jacket, we didn't have to think or be elegant. We just went in, put the stent, post-dilated. Sometimes we had 40% residual even with the stent because we didn't prep the vessel. So we learned so much. Now we need to be elegant. We need to be operating like Peter, doing these things if we want to get optimal results. And I think doing an angiogram at the minimum after atherectomy is critical. Now, then based on that, whether you do pre-dilatation with a balloon or you go back with your atherectomy and find those areas that you need to optimize, then I think that there are different approaches.
Do you believe that there is a role for the chocolate balloon here in order to avoid this bailout stenting based on dissection? I don't know how reimbursement works in your country with regard to combining different vessel prep systems. In our country, we are only reimbursed for one. So if you use atherectomy, chocolate is reimbursed as a regular balloon. So we have no revenue from that. So what's the situation in your country?
Reimbursement is the same as regular angioplasty. I think there's a huge role for chocolate. I've been very impressed by the chocolate bar registry results in terms of decreased dissection, but then also in terms of clinical utilization. You know, in below knee territories where I can't or don't want to get an atherectomy device, if I can deliver chocolate, that becomes a primary therapy for me there. You know, there's situations with directional atherectomy where you can't necessarily cut down as far as you want to cut down if you're coming on the border of your embolic protection device, or if there's some reason why you can't advance that device. I've used chocolate very successfully in those situations as well. I don't routinely use it as an intermediate step. Because I think if there's a recalcitrant area, that's something I'm gonna try and use the tool that I already have open a little bit more. But with regards to clinical utility, I think it's a wonderful device.
You know, I am biased, Tomas. I really like the device, to be honest with you, especially for below the knee. I think in the SFA pub, we have so many options, you know, directional atherectomy and DCB. I mean, especially in the US, we have so many options, but in the below the knee, we are limited in US. So for us, I think that I think it's more efficient than using atherectomy for some of the tibials. It allows me to be much more aggressive with the sizing, because of the design of the balloon with the stent and the nitinol cage. So I tend to use it more in the tibial and the popliteal area, more aggressive sizing, and occasionally I've used it in combination with the directional or even orbital atherectomy. To be honest with you, I think if you have very heavily calcified lesions in the tibial and you do orbital and then use chocolate, the results can be impressive.
That's true. So, well, it will be very interesting to see the reality data be presented in fall, I believe, so that at Viva timeframe, the final data analysis should be available. Hopefully we will be able to convene there. I have my doubts, unfortunately. What was already discussed before, traveling is not so easy in those times. So anyhow, I believe that we are finished now with our transmission time, and I would like to share some closing remarks with you to finish here. Let's get started. Oops. No, I'm sorry. I need to get to start. Okay, now. Good. So what we have learned today is basically that drug-eluting balloons are definitely superior with regard to primary patency and reintervention rate as compared to plain balloon angioplasty. So referring to the recommendation of the FDA to discuss in depth the use of DCB even in easy task A and B lesions, I would say this is a clear message that we need to inform our patients that even simple lesions deserve the treatment with a drug-coated device. Second, we have learned, well, we have good long-term data, and the hardest data that are available with regard to outperforming plain balloon angioplasty by a DCB is coming from the IN.PACT study series. It's for sure the biggest series ever conducted so far with regard to evaluating a DCB. We can see that there seem to be difference in performance between different DCB brands. Important to note is that we are aware that even a meta-analysis is regarded as level 1 evidence in science. We have so many conflicting data not supporting the finding of Katsanos with regard to the safety of drug-coated devices that I personally believe that we need to go on offering our patients the use of DCB and also DES, because they are at the moment our best treatment tools we can offer to patients with intermittent claudication. And post-hoc analysis and analysis relating drug doses to mortality did not confirm any relation between drug dose and mortality risk. So what we learned is that based on the IN.PACT SFA trial, there is a 73% reduction in a reintervention rate at 12 months, clearly demonstrating that the IN.PACT Admiral DCB is one of the best treatment opportunities we can offer to our patients, even in the light of the mortality risk discussion. Having said that, I would like to thank all attendees. I would like to thank the entire panel, which was participating in this 1-hour session. And I hope that you enjoyed this session. And the message should be stay with DCB and inform your patients correctly. Thank you very much.
Thank you so much, Thomas and everyone. The structural session will start at 1:30 Mountain Time. Thank you again.